Welcome back to the Atlas of Chiropractic podcast. Got Dr. Cameron Bearder with me and Dr. Priya Mistry. You might know her from Instagram as the TMJ doc. But she was previously a guest on Dr. Kevin Pekka's podcast, Expect Miracles. That's where I became familiar with her and her work. And I want to just say, Doc, before we get into a lot of the content here, I always appreciate when a clinician who's trying and really doing high-level clinical work also goes out of their way to make content, because there's such a lack of understanding of some of these principles that we're trying desperately to help our fellow man with. So you do end up sticking your neck out a little bit, and you have to develop the courage to be out there. There's a lot that comes with a couple tens of thousands of followers on Instagram and YouTube and everywhere else. So I just want to first acknowledge and tip the cap to you, because I think that's important for folks to see reasonable voices, folks that are doing high-level clinical work, to kind of introduce these concepts, because then they can actually make their way into offices and find help, and that's what matters most.
Yeah, thank you. Yeah, you kind of have to have thick skin to do this, right?
Yeah, no doubt about it. And Dr. Priya is in private practice in Vancouver, Washington, and you have your own podcast, the Unclenched podcast. So I'll make sure the links for her website and also the podcast are in the show notes, so you guys can go back and reference previous episodes she's done with her co-host. But we're really going to get into some concepts related to craniomandibular work. So we focus in the craniocervical side of chiropractic, and you focus in the craniomandibular side of dentistry. Cameron and I, as we've been involved over the last several years, these concepts keep coming up. Right? We see consistently there are these other systems of the body that influence the work that we want to do. Right? As we continue to learn and grow and try to think full picture with these people and assess all the systems, there's so much to consider when you think about occlusion and the TMJ joints and the orofacial structures. We want to talk a little bit about that. We can't get into all the details, but we want to give folks at least some talking points to dive deeper into. So if you first would maybe introduce yourself, how did you get involved in dentistry and then into this field that you're in now?
Yeah. So I started practicing general dentistry in 2007. And then I met my mentor 11 years later, and I started shadowing him kind of on a whim. I just thought, what does a TMJ doctor even do? Like, I didn't know how to treat it. We weren't taught a whole lot. And I went to a really good dental school, and we just still weren't taught much about it. And so I thought, I'm getting like 3, 4, 5 patients a year who can barely open their mouths. They're in so much pain. And I just give them a muscle relaxer and kind of hope for the best. And maybe a night guard, maybe something, if I can even get impressions of their teeth. Sometimes they're so limited. So I thought, I could probably learn something from him. So I started mentoring Dr. Arthur Parker, who was like the TMJ guy in Portland for many years. And I was just hooked from day one. I told him I want to buy a practice, and he was kind of like, okay, well, you have a 2-month-old and a 2-year-old at home. Like, I don't know. And it's a steep learning curve. I did have to take a step back in terms of pay, in terms of everything, just to learn all of this. And I just feel really incredibly fortunate that I even met him and got to learn from him. So ever since then, that was 2018, and I haven't looked back. I bought the practice in 2021, and I moved it from Portland, Oregon to Vancouver, Washington. And here we are.
I want to just kind of make a quick comment for the students that are listening. So this is a doctor who's practicing for more than 10 years, out shadowing and getting into atmospheres with other clinicians to learn more and understand more. That's incredible and inspiring. And so I hope the students caught that point, because it's not a finished product, right? When we come out of school, we are not equipped to handle the folks that we see as well as we want to. And so you have to continue your learning.
Yeah, I think it's so important for all practitioners, whether you're a chiropractor, a dentist, an MD of any modality, anything really. You just have to keep an open mind. And the one thing you should know is that we know nothing. Just, there's so much out there that we still don't know about. I think just a couple of years ago, these other salivary glands were discovered that had never been found in dissections before. There's so much to know. And I just think that to take those opportunities, seize them, and learn as much as you can only help more people.
Doc, you made an interesting comment about you weren't taught much about the TMJ in school. Why do you think that is? And how do you think that's changed over the past decade, 2 decades?
It's definitely not changed, I can tell you that. But I think it's because A lot of people don't know how to diagnose whether the problem is coming from the muscles or the joints or the neck
There you go.
or what's causing it. And TMJ problems can really come from all of those, some combination of those, and what causes them. Like hypermobility can cause them. That's not very well understood. It's just up and coming that they're starting to do more research on it. Different postural components can contribute to jaw problems, like if your hips are off, your bite, the way it comes together, whether you've had several whiplash incidents or car accidents. So all of those things can come together, or it can just be one of those causative factors. So I think if you don't even understand the cause of it, how are you going to even begin to do the research on it? And everything we learn is so evidence-based. And of course that's important, but it's just really hard to gather evidence on this. I mean, it could be a lifelong thing. And so I think that's the main reason is there's just not a ton of evidence. And there's a school of thought out there that thinks like placebo or stress management can help get rid of TMJ problems. But if it's a structural or alignment issue, or if your bite is playing a significant force in it, there's so significant factor in it. There's so many different things that are not being addressed. If you're just saying, well, de-stress and placebo.
That's so interesting that pain science, biopsychosocial stuff is bled over into your space too, because we get a lot of that in the musculoskeletal rehab world.
Mm-hmm.
And it's almost to minimize some of these concepts that some practitioners think are maybe overemphasized.
Mm-hmm.
And you certainly can't meditate your way away from a structural problem, which a lot of people have. And it's, when you talk with folks about the history of injuries, there are so many layers of dysfunction for a lot of people by the time they wind up in front of you that it can be overwhelming. It's almost too much data to process.
It is. And like the fascia plays a significant role. There's so much. And, when dissecting cadavers, we're just moving the fascia aside and trying to get to the organs and the muscles and all the good stuff. But like the fascia is the good stuff. It's super important. And I just feel like there's not only not an understanding of that, but an appreciation for it in the dental world in general. And I'm hoping to, with my content that I'm putting out there, to kind of change that. And I'm going to be creating courses for dentists and et cetera. So I have all these plans, but there's not enough hours in the day.
Where do you think, what structure do you think from a fascial standpoint is most commonly involved or most commonly overlooked?
I think the entire fascia, since it's connected through the whole body, all of it is overlooked. I just feel like people don't even think about it. Yeah. And they're just like, well, manage your stress, you'll feel better. And it's like, well, if the fascia has constriction, if it's like really tight and constricted, that's not just going to let go magically if you reduce your stress. So I feel like there are hands-on therapies, the orthotics that I make, the way that I treat, they help to hold the muscles at their correct resting length, their most relaxed position. And when the muscles relax, the fascia has a chance to let go. But the body work helps a lot too, like releasing that fascia manually. And so I think we've moved away from that and we try to fix everything with pills. That's just, I don't know. I just don't think it's effective.
Well, it's funny you mentioned some of these concepts because some of this is what got me interested in upper cervical chiropractic. Thomas Myers' anatomy trains and Buckminster Fuller's biotensegrity concepts, and some of this idea about the fact that the skeleton does not support itself. Right? It's like we're not blocks that are stacked up together. We are resisting gravity through the tension profile of all these soft tissues, and our bones give us structure and provide joints for movement, but it's not the whole story.
Right.
And I think especially as chiropractors and folks in the dental field that are so osseous in our thinking and intervention, it is important to remember there's a lot of other bits and pieces that coalesce and work with that stuff. For listeners that are interested in this stuff, go back and listen to, we did an episode with Dr. Frank Scally on the myodural bridge and how, there's suboccipital musculature influences things like the tension in the dura and the cranial structures and how that influences global posture through neurological mechanisms, all these things, right? It's a lot, but it's all really important. And so I'm hearing like you obviously approach things from a functional standpoint, and it's that intersection of structure and function that you're really trying to like fine tune.
Yeah. And I just think my mentor had such a unique way of doing things. Like he got trained in craniosacral work. And so I got trained in craniosacral work. And like I tried to just do whatever he did because what we do works well. So I wanted to learn it as well as I could. But I didn't even know what craniosacral therapy was when I started working. I was like, what? What are you talking about? So I just remember being like, okay, is this hokey? Is this woo-woo? Like, I went to my first course. It was in San Francisco, and there were no other dentists, and it was just a very different experience for me, right? And so, but again, keeping an open mind is super important, and I think it that and learning as much as you can really gets the results for these people that are suffering.
Absolutely.
100%. Well, let's get into maybe some key concepts with craniomandibular work. Like, let's maybe define some terminology, because we have a lot of students that listen or docs that may not be up to speed at this level of conversation and where we're going in this conversations. Maybe let's quickly give folks an overview of when you're assessing patients, what are the structures, what are the key findings that are evidence that there is a craniomandibular issue to be addressed.
Yeah. And Dr. Prabhu Raman, I don't know if you ever come across him. He might be a good one to have on here too, because he actually calls it CCMD, craniocervical mandibular disorder. So he just puts it all together because he's like, it really goes all together. And I find that to be very true. So for my examination, I do a thorough history. I start by having them tell me their entire story. When anything started, I ask them if they've had any history of injury to the head, neck, or jaw, if they ever had braces, if they've had teeth extracted. I basically get their life story. And then I do the physical exam. The physical exam is super important because I do a very thorough muscle palpation exam. So I'm feeling the muscles around the head, neck, and jaw, and I'm asking for their feedback. Do you feel only pushing? Do you feel tenderness? Do you feel pain? And we document all that. And that gives me a pretty good idea of what state of health or dysfunction the muscles are in. We do a good jaw range of motion exam. And sometimes I'm even checking neck range of motion because, again, it's all related. Then we also do a postural exam. So I have them stand in front of this grid, and I'm checking to see if one shoulder is higher, one hip is higher. We have them turn to the side. I'm checking for most of my patients have the tech neck, as you call it. And of course, an occlusal exam. I'm looking at their bite. And by the end of the exam, I pretty much figured out what's going on. And so we diagnose based off of that, and we just sort of go from there.
You didn't mention imaging. Cameron and I both have CBCT in our office, and we're looking at imaging.
That's awesome.
So we're seeing these structures in front of us all the time, and are wondering what we're missing, hidden in plain sight. But what role does imaging play in your assessment then?
Yeah, it's a huge role. So every patient gets a CBCT. I just don't do it at the first appointment. So that's why I didn't mention it. Yeah. So I look at, that shows me the bony components of the joints, the upper cervical vertebrae. I'm looking very closely at those, and then I know which referrals may be appropriate as we move through treatment, depending on what I see there. I'm looking at airway because TMJ and sleep apnea often come together. So I'm looking at airway, and then I send it to a local radiologist to look for anything like my eyes are not trained to see. So I feel like the imaging is huge, and the CBCT is like a must unless the patient's pregnant. Sometimes I do request an MRI for the jaw joints. It just depends on what's going on exactly with that specific person.
Yeah, you're not going to get the disc in a CT scan, and there's some other important info.
You see a couple shadows now and again. If you look hard enough, like you can, I have several patients where you can actually see like almost the lucency of the disc, kind of like as it comes around that front portion of the condyle. And like I'll look bilaterally and I'll see, oh, wait a minute, this one looks like it's deviated anterior. This one looks like it's shoved backward. If you kind of play with I have an iCat. I know John has a different imaging machine, but like if I've played around with some of the factors, and maybe I'm hallucinating, but I swear I can see there's a little bit of that disc. And then
I think if you play with it, you could probably see it a little bit. I just don't feel comfortable diagnosing off of that. So I just kind of look, and then I'm like, let's get an MRI.
Yeah. Dr. Tamimi was a previous guest. She's a maxillofacial radiologist, and we talked a little bit about some of the things to look for, but she kind of put me onto Dr. Rockabato's work. And then also just even in her textbook, I was, my mind was blown reading about this like tricentric model of occlusion, which is kind of what you're talking about. You think about the neck, you have to kind of think about the jaw and the teeth touching as well, because that's extremely relevant neurologically, but structurally too. Is that a concept or, sort of like a structure framework that you work within?
Totally. Yeah. And I mean, I think Dr. Corey Burt, he's the NUCA guy that I work with over here. He explained it best. He said, try to move your lower teeth. How do you do that? And he moved his jaw around. And he said, try to move your upper teeth. And he goes, you can't do that unless you move your head. And what moves your head is your neck. And so when he adjusts my patients, I have to see them. I'd love to see them right after, but we're quite a distance with traffic and everything from each other. So I usually see them within 24 to 48 hours to adjust the orthotics to help hold what he did for their neck. And we've seen really great results. I think we have a testimonial with someone named Kim. She's lovely. So if anyone wants to check that out, it's on my YouTube. But it's just really cool, like working together and getting these amazing results.
And then that starts the conversation about ascending and descending problems too, functionally. Do you want to maybe, because I know a lot of the listeners will have not dove into any of these concepts. Like, would you define those so that folks can have an idea if they start working with more dentists, they can understand the terminology?
Yeah. So my mentor always called it the postural chain, and it's the feet, the hips, the entire spine, the shoulders, and the jaw. And so one part of that postural chain, one component of it, if it's off, like if one hip is higher or rotated, it can feed up the spine and affect the jaw, or vice versa. A really imbalanced bite can feed down the spine and affect the hips. Different parts of that, again, everything's connected. So different parts of that postural chain can affect one another, feeding up and down the spine. But my mentor always said a really good TMJ orthotic will help stabilize things to a point. It can help chiropractic adjustments last longer. It can help physical therapy, all the benefits of it last longer, etc. Yeah, that's kind of what I see a lot of.
Yeah, and I'll explain it to patients like this because a lot of times they've seen other chiropractors who maybe had a different thought process about how to prioritize things. I always tell folks, like, neurologically, we're going to think from the brain down in general terms, and biomechanically, we're going to think from the feet up. And the intersection of the two is probably where your problem is, right? And for some folks, it might be more biomechanical. For some folks, it might be more neurologically driven. But both of those things are always available, and always an option. And there can be comorbid conditions like affecting either one or both that all influence the symptom profile. When you're dealing with folks, I think that'd be an interesting thing to point out. What are some of the key physical symptoms that folks experience that would lead them to your office in the first place?
Yeah, I think what I've been seeing a lot of lately is the jaw locking closed. So it's a condition where you can open, but you can't open to your full range of motion. So you can open maybe 1 or 2 finger widths. Normal is considered 3. So that what happens in this anatomically is the little disc of cartilage becomes dislocated. It gets stuck too far forward and in. And then once it's stuck there and dislocated, it serves as a barrier to opening. Those people generally have something going on with the upper cervical spine too.
Interesting.
And that's something I think Roccabato talks a lot about. Mariana Roccabato talks a lot about. So I've been seeing a lot of that, and that comes with a ton of pain because when the disc is dislocated, the muscles go into spasm, etc. And then headaches. Headaches are actually the other reason people come to see me. So they may have no clicking or popping noises in their jaw joints. They may never have gotten their jaw locked or stuck, but they have chronic, sometimes daily headaches. I saw a woman who was just at her wit's end. Her teeth were ground down to nothing, and her dentist wanted to do all these crowns, and she was like, I can't even sit through a cleaning. How am I going to get through all this dental work? My head is killing me. It's making me grumpy. My husband doesn't want to talk to me. I'm like, okay. So we got her into treatment, and she felt better within 2 or 3 weeks. I mean, like, she was like, this is life-changing. I love this. And, so headaches are huge. Ear pain, dizziness, neck pain, stuffy ears, lots of different things. But ear pain, headaches is a big one. And ear pain, actually, too. I've seen a lot lately.
See, so this is, whenever I hear, because what you just described, Doc, is you described what upper cervical chiropractors see as well. And I think that's always the key. And John and I were talking about this before you hopped on, is how can we determine, what's the primary or closest to primary of, like, is it the temporomandibular system? Is that playing the biggest part? Is it the cervical spine? Where should people start? And, like, what are the indicators that we should all be looking for to make that appropriate referral? Because, we see headaches all the time. We see dizziness. We see ear pain. Kevin Pecca talks about he's done really good with Meniere's and things like that. Yeah. I know Corey, Dr. Burt Nuka tends to see a lot of low back pain type stuff as well. But it's always interesting hearing someone who focuses on this area say pretty much exactly the same thing that we're saying. And I feel like if we could come together as kind of like a group and figure out within 5 minutes, 10 minutes, like, boom, this person needs to go see you. First, a lot of people would be helped potentially a lot faster. Because I'm always curious. You'd mentioned Dr. Roccabato, and I've only just found out about him about probably the past 6 months, and I would love to go and learn from him. But when you say that the TMJ disc, they're an issue there coming from the neck, can you expand on that a little bit? Because that's something that I haven't heard.
Yeah. So Dr. Roccabato's whole thing, I believe, and I haven't gone to one of his lectures or anything, but my mentor did. And then I watched his lectures on like old VHSs that my mentor had.
Cool.
I was watching those. But basically, he talks about the upper cervical spine and the musculature there. And if that is dysfunctional, if everything's tight on one side, it yanks on everything, including the jaw. Right? Like the SCM connects to the mastoid process, which is part of the temporal bone, which is part of the temporomandibular joint. So if things are being kind of yanked out of alignment from here, it affects the joint. And if somebody's bite pattern is already predisposing them to the disc coming out of alignment, then you've got two factors working against you. You've got this bite pattern and your neck. So everything just gets pulled out of alignment more easily. So I think I don't know how much Roccabato touched on the bite, but that's I guess my addition to that. But he came from the approach of like the neck.
Yeah, which, heavy cervical
great work. Yeah, does great work.
He still teaches. I've been trying to find something in the States.
I know,
without having to go.
Popping up on my Instagram creepily.
Me too. Yeah. So I almost impulse bought one of the courses, but it was like pretty affordable, and I wasn't really sure if it was legit. So I kind of
like, this can't be legit. This is a scam.
Well, is it in English? Is it going to be in English? That was my biggest fear, because he co-teaches a seminar on CBCT and MRI with neck and temporomandibular, and I'm like freaking out, like, whoa, this is it.
Yeah.
So I'll just take the plunge. I'll just do it. Who cares if I can't understand it? I'll roll it through Google Translate, and we'll just kind of
someone has to
figure it out.
I want to go to the one in person. There's just not enough hours in the day, but I do want to go to one of his courses, and I do think it would benefit patients if we all did find a way to come together and like being able to diagnose them accurately, get them into treatment. The imaging is required, I think, for an accurate diagnosis. And then also, like, I just got introduced to T-scan. Have you guys heard of TEC scan or T-scan?
Like the sort of force profile of the occlusion.
Yes. So I
crazy, isn't it?
It's amazing. Crazy. I've already treated a few patients with a lot of success with that. So it's like sometimes even just balancing the bite to make it so the muscles aren't as activated calms things down enough, even in the neck. So I just feel like,
And this is the kind of thing that Cameron and I talk a lot about, just kind of interdisciplinary about chiropractic. We have so many differences of opinion about how to sequence things or what's the most important first thing. And I've learned just interfacing with dentistry a little bit on this stuff. Like when you talk about TMJ and occlusion, I mean, there are all out, sort of like wars about what's most important. You got some folks that it's all about the joint. Some folks, it's all about occlusion. Some folks are, very fixated on the airway and will, almost neglect the occlusion to the point of like creating space. And it's all a related system. And I know we all have our piece to offer, and whatever we get really fixated on, we can go deep on and then bring that forward. But when we're thinking about sequencing things, because this is something that, the way I got introduced to any of this in the first place was this forward head position, right? Chiropractors were supposed to help with spinal alignment, right? So we see these folks with persistent, kyphosis of the cervical spine. It's like, what in the world is preventing our treatment, to your point earlier, from being successful in the way that it should? Like, why is the body jamming this head forward
to open the airway?
Exactly. And I had a lunch with a doc here in town when I first moved into town, was setting up my practice and looking for a CBCT. And he said, what's the most important thing? Your next breath, right? So he was a big airway guy. And I was like, well, you're right about that. Like it's a interesting way to put it. And he goes, if you can't breathe, who cares how your teeth touch, right? But it's one of those things that I'm curious, when you're thinking about sequencing or, where you want to start your intervention, how do you go about, picking and choosing which of these functions is maybe the most important?
That's a hard one. I mean, they're usually coming to me with pretty significant pain, and they can barely open their mouths, right? So it's like that is their top concern. So I always take their top concern and make it my top concern. And then I'm like, is it okay if I add these as like the next concern? And they're like, yeah.
Good
So
for
I
you.
kind of make this list of priorities of like the goals that they want to attain through treatment and what I want to get, right? For them that would benefit them, right? So I always approach it from that standpoint. If their number one reason for coming to see me is headaches and I'm just making no headway with my treatment, that's when I say it's probably a good idea to get an upper cervical chiropractor involved. So that's pretty rare that I have to do that, because I think why is because the orthotics just relax all the muscles enough for things to let go, even if it's not perfect alignment here.
Yep.
If their number one thing is that their jaw is locked closed, they need to start with me. If their number one thing is, I'm pretty sure I have sleep apnea and I have really bad TMJ problems, they've got to meet with a sleep doctor, because sleep apnea could kill you, right? I mean, it really could. And so I just kind of gauge it on like what they're looking for. And then I also just keep them informed every step of the way. There are some people who would swear up and down they don't have sleep apnea. And then I look at their CT scan and their airway is like nothing. And then I say, I really encourage you to meet with a sleep doctor. I really think something may be going on. They do that, and then they get diagnosed with sleep apnea, and it's like, they're like, oh my gosh, I've been told I have chronic fatigue syndrome or that I have fibromyalgia, but it was actually this all along. And so I gauge kind of where they're at, and then I look as objectively as I can at like all the data that I gather, and I just talk to them, and I just say, this is what I see is going on. This is what I think is going on and causing it. Let's move forward. This is my recommendation. What would you like to do? So it's really hard to put it in like an order it's really hard to put it, because it depends on what's bothering them most and what they're looking for.
And that was kind of what I was teeing you up for, because Cameron and I have both come to that conclusion over the last several years practicing too. We were kind of trained in very, tight parameters of treatment algorithms and things like that. And it's always supposed to work out this way. And this is the way you always work through it. And we found that that's just not, it's going to leave gaps for folks to slip through, and if we are wanting to be mindful to be a better second option, for more difficult cases that just don't respond to conventional management, then we got to be closing up those gaps that folks fall through, right? Because those are the folks that are going to fall through the gaps into our offices. Mm-hmm. And so having an individualized approach led by the patient's goals and their primary detriment to their quality of life, which is probably their symptom, right? That's the best first place to start. And then you can, and I tell folks this all the time, like, you don't have to have perfect alignment to feel better. And we definitely want to use what we know about your alignment as a lever to move towards better quality of life and function. And we can finish the job if that's what's required and take it all the way there. But, depending on how you progress through this, we'll decide if that's what you need or not.
Changing to them. And so that's something I always have to keep at the top of my mind, because I always want to get everyone 100% better. And I'm like, I just have to kind of back off a little bit and think about it and like kind of let things go, because if the patient's happy, why would I just keep pushing and pushing and pushing? And so it's a hard thing, because it's like we really want to help as much as possible.
And if you've got a trigeminal neuralgia patient sitting in front of you, or someone that has a really intense neurological pain syndrome, there's a sense of urgency about getting results, right? It's really important that these people feel relief in a short period of time.
In a short, and I think that's it's turning into a problem. I'm just, my other practitioner that was with me retired, and I'm like, I don't know how I'm going to do it. So, I mean, I think one of you guys should move next door to me.
That'd be great.
Well, I mean, Corey, if you got a relationship, my first thought was like, if Corey's that far of a distance, you guys should be right near each other. That way,
I told him that too. I told him to move.
I think John and I have talked about this for many years now. There is likely, just especially post-COVID, with just how expensive it is to run a business and overhead, we're going to see partnerships between dentists and upper cervical chiropractors and PTs and like it's going to be one of the only way to survive, or only ways to survive.
Like to make
It
these
is.
wellness centers, because
Yes.
people
100%.
can really benefit from all of us
Yes.
coming together, like the Postural Restoration Institute, physical therapists, upper cervical chiropractors, dentists that really are skilled in treating TMD. The three of us together, we could move mountains, guys.
I'm with you. And I think it takes a special blend of people, right? Because there's a certain level of humility that you have to go in and say, for this patient, maybe my thing's not first, right?
Mhm.
Maybe Dr. Priya is going to take the lead on this, and maybe I will supplement her care or vice versa. But I dream of that. Like, I think that would be such a fun, collaborative environment. And can you imagine the value to a patient? You get multiple highly trained specialists
I
to
know.
just handle
Yeah.
your case as detailed I mean, that's incredible. That's Mayo Clinic type of thing, but like with excellent results that restore function, right? Get the body to work better on its own again.
Definitely. And I think, there's just such a need for it. I mean, 86% of people experience, we'll call it CCMD now, because that's what Dr. Rahman calls it.
You heard it here, folks. That's official.
You heard it here. 86% experience it at some point in their lives. Now, whether it's severe enough for them to seek treatment for it, or if it maybe goes away on its own, I'm not saying 86% of people are out there debilitated, but at some point experience something like this. And it'd be amazing if we could all come together and just get them the best treatment as quickly as we can to get them feeling better.
I tell you what, with cone beam, at least in my experience, cone beam to me has solved a lot of the potential kind of not barriers, but maybe hurdles, because you use cone beam, now we use cone beam. I'm sure some sort of PRI, they could glean stuff from cone beam as well. So like instead of doing all of these images, like upper cervical chiropractors take x-rays and dentists take dental x-rays or cone beam, it's like, wow, now we can take the same image and we can all analyze that image for what we're doing. I mean, and it seems so simple now that you could all three sit in front of a screen and say, well, let's like basically trial this. If the airway looks like this, what's happening here? If the atlas or the craniocervical junction looks twisted, what's that doing to the airway, or is that causing all of this stuff? I feel like it could probably be solved a lot faster than we could ever imagine. Yeah.
Adjustments on the orthotics right after they get their neck adjusted.
Yep.
Everything would go faster. And it's just not set up that way yet.
It's not. And I think there's the potential to help more individuals, right? Like if there's less visits required to get to the end goal, that opens the door for more of that 86% to actually have their need met, and that's a problem of scale that I think, when we do this kind of work, it's really hard to think about how you're going to see, I don't know, how X amount of patients in a day. You can run yourself ragged and it's still a drop in the bucket for what the need is.
I know. And I feel like I'm getting to that point. I'm just like, oh, I don't know how I'm going to do this. So I hear you.
So how are the organizations in your world helping promote these ideas? I know you're involved with ICMO, if you want to explain what that is, and then maybe for folks that are searching for dentists that may be trained at this level in their communities, like how would they go about finding someone who's qualified at that level?
It's really hard because so ICMO stands for the International College of Craniomandibular Orthopedics. So it's quite a mouthful of a name. But most of those dentists, I would say maybe all of them, have had some training in using neuromuscular dentistry. So a type of dentistry that uses technology, software, instrumentation that finds where the muscles are sitting at their correct resting length. And if the buck stopped there, it'd be really easy. But there's so much more. Like you have to use that technology and your knowledge of the patient's condition to then tweak the prescription that you find to make them the right orthotic. Now, finding an ICMO dentist is not hard. You can go to the ICMO website, but do they have the same level of experience that I do or that my mentor did? I'm sorry, I'd say most of them don't. Some of them do. There's a handful of referrals I make in the entire country, and then that's it. And so that's what's kind of like tough about it. And I'm not even tooting my own horn. I learned all this from my mentor. I'm tooting his horn. But it's really hard to find somebody that can, and especially when the jaw is locked closed. So that's called disc displacement without reduction. That condition, a lot of ICMO dentists don't know how to treat that. Some of them do, but a lot of, like, many of them don't, especially the ones that are newer to ICMO that are just getting their feet wet with the TMJ stuff.
Yeah, I think we've observed the same type of phenomenon in our industry too. Like if you look at a directory, you know, folks that have been to a conference in the recent history or joined an organization and paid their dues, like they'll be listed there, but that doesn't necessarily qualify the level of training or experience, or if they're even following the standards of the organization that they belong to, kind of a thing. Yeah. So we get that, and it ends up being a networking challenge of like, you're going to have to vet people for yourself almost, so that when you do make these referrals, you can feel confident about what's going to happen on the other end.
I've had people get mad at me because I just started referring to ICMO thinking, oh, it'll be fine. I've had people come back and say, why would you send me there?
Yeah.
That was the worst experience of my life. He was such a jerk. I'm like, oh my gosh. So now I'm like scared to make referrals because I got in trouble, and I'm like, and I get it. I get why that person was mad. You know, like they came to me hoping they could get help. Like I could refer them to someone, and I didn't make a good referral. So there's only a few people I trust in the nation.
And
people are willing to travel now, though, and that's something, especially post-COVID. People, I mean, we've had people from all over the country come to my office, from all over the world. It's been crazy. People are literally, I mean, they will, if there's a good rapport, and I spoke with a guy in Connecticut today who's going to be coming down, and people are willing to travel for hope, and they're willing to travel for, for people who are doing good work, and not just, come in, okay, we're just going to do this and fit you with this appliance, and then that's all we're going to do. Like it's hard. I feel like it's hard to find good doctors, but it's also really easy to find good doctors as well, in that social media is ablaze with this. You kind of have to have a couple neurons to be able to figure out, like, is this person a schmuck or not? But you can, for the most part, I feel like you can genuinely tell when there's a sincereness, and people are willing to go out of their way tremendously to get good care. That has been very apparent.
They are. Where are your practices, respectively, both of you?
I'm North Carolina.
I'm Colorado Springs, south of Denver.
Okay, I thought you were Colorado. Okay. Yeah. I mean, we're all far from each other. I'm like, when have you guys moved here?
Well, I there's so many places I want to be at the same time. And I know Cameron and I have both mentored a lot of students, and we're always in conversations about, like, what you're doing is, how do we create content or opportunities for folks to get access to information we didn't have? And as we've accessed it, has changed things for us and our patients in significant and profound ways. And that's why I appreciate you being willing to have collaborative conversations across professions, is because that creates awareness. If you're a fifth quarter chiropractic student, you've got 2 more years of school before you're even, trusted, to get a license and deal with the public. And you're already listening to conversations about these concepts. And that becomes the standard at which you think and manage patients through. And that's kind of our objective, is like, let's just start the conversation at a high level, get everybody to join in at that level, and make that the standard. Because then when you get into practice, it won't take you 10 years to go find a mentor that can help you. It won't take you 5 or 6 years like it took us to go, outside of our bubble to learn what we've learned. And it's such a, there are so many like minds. It's just a funny thing when we deal with different professions. There are so many like minds. We find the people that are like us in this profession, and it's like an instant connection because our patient care philosophy is similar, which is, we want what's best for your life. We're not going to run you through our protocol. It is you. Your best result is our intention. And then there's high level clinical work and dedication and work ethic there. It's powerful.
Totally. Yeah. And it's like so exciting when you find somebody like-minded. It's like you could talk for hours and hours.
Yeah.
Doc, forgive my ignorance, but do dentists have a residency after formal schooling?
No worries. Yeah. No, it's not required. So some people go ahead and do one. That's like a advanced education in general dentistry. So that's the AEGD. And then, so you can do one, but you definitely do not have to.
Okay. And then there's diplomates, like specializations in different areas right? So like,
Yeah.
okay.
Yeah, like if you apply to like you mean like an orthodontist or an endodontist?
Yeah, or the
Dental sleep
craniomandibular
medicine or
orthopedics. Yeah, like it seems like there's a high level of specialization as well.
Yeah, there's like the true specialties that you have to like apply for in dental school or after whenever, and you get into those programs like to become an orthodontist or a pediatric dentist or an endodontist or a periodontist or a prosthodontist. So those are like the
Got it.
main ones. And then anyone can take CE courses on sleep medicine or TMD. But yeah, like my letters, if you look,
Hmm.
it's Diplomate of the American Board of Dental Sleep Medicine. So that was me taking a bunch of online courses and then actually submitting some cases that I did with patients to make them oral appliances to treat their sleep apnea. So
Yeah,
it's not a true
absolutely.
specialty I can't call myself a
Yeah.
sleep specialist, but I am a diplomate of that, and I have
Hmm.
gone through
Hmm.
a decent amount of training for it. So there's the true specialties, and then there's like the stuff that you can pursue on your own. And I think everyone just picks what interests them the most.
Absolutely.
yeah.
Yeah. Is there
Cameron and I
a
are both working through a diplomate program right now. We don't have that specialty like the endodontist. So we're
Yeah.
doing a diplomate in chiropractic cranial-cervical junction procedures, but I think after today we're going to lobby them to add the M,
yeah.
diplomating
Yeah.
chiropractic cranio-mandibular cervical procedures.
Yeah.
How's
Yeah.
that?
Oh, I think that's great. I feel like how are we going to merge our worlds? That's something we could work on.
Yeah,
That
absolutely.
I think it's I really think that with the adoption of cone beam and upper cervical,
Hmm.
there's never been a closer
Hmm.
a narrowing of the gap,
Yeah.
because you take one image, right, and multiple people can look at it. To me, that seems like that would be the spark that kind of ignites the powder keg.
Yeah. It's
I mean,
exciting.
we need to get you to come speak at some of our conferences. I feel like that's honestly that's the second way that we can get this kind of cross interprofessional, because I mean there's upper cervical chiropractors who don't really know much about craniomandibular or craniofacial or any of that stuff, and I think that they should, but sometimes you have to put it in front of them. But you've got folks like yourself who are extremely well educated and extremely well versed, and that's how we, as John says, start the revolution is we we start speaking to each other's camps.
We have to. I think that's so important. And I think I'm not sure if ICMO has ever had an upper cervical chiropractor speak. Like I've only ever gone to one conference. My kids are really young, so I wasn't able to go until more recently. But that's a good idea. So I'll reach out to them and see. I think ICMO, the international one next year, is going to be in Japan. So if you want to,
Very cool. I'll
there,
twist my arm.
twist my arm.
Yeah.
Hey, listen, Doc, we really want to be respectful and mindful of your time and appreciate, this first conversation. I'll call it first because hopefully we can follow up and have more over time.
Yeah, definitely.
But I want you to let folks know where they can connect with you. I know there
Yeah.
are some patients that listen to this, prospective patients that are searching for help. We have a lot of students and other doctors that listen. How can they connect with you and gather more information about what you're up to?
Yeah. So if you're just looking for more information, I mean, I've got a ton I think my Instagram is the most followed that I have, but YouTube has like really nice longer form videos that are like easier to digest. Instagram, TikTok, everything's like so fast, right? I had a patient tell me the other day, really cute older lady, she was like, your Instagram is great, but it's just so fast.
Aw.
Can't you make longer videos a little slower? I was like, no, lady. Like, I was like, I love you. Instagram only allows 90 seconds. And she's like, it does? I didn't know that. And I said, yeah, all my longer stuff's on YouTube. So I gave her
That's
that and she
cute.
was like, oh, okay. It depends on how you digest information, right? So I think there's a lot of information there. I'm in the process of updating my website, but there's still information there. And if you did want to, you could always set up an online consultation with me through my website. There's a fee for that, but my website has all that information. So I think that's like the best way to learn more about it.
Excellent. I'll have the links for all those here so folks can just quickly access those as they listen in on the conversation here. But any last words of encouragement for the listeners as we wind down, particularly for the younger docs or students that are hopeful, but also, eagerly awaiting life in practice?
Yeah. Well, keep learning. I mean, don't ever close that door even after you finish school because there's so much to learn for all of us. And keep an open mind and open heart, collaborate with those around you. The more people you know, the more people that are like-minded, like you were saying earlier, Doc. I just think building and holding on to connections with people like that is so important. Attending the conferences, learn. That's like the main thing.
Beautiful. That's a great way to wind it down. I'll stop there.